Dear colleagues, it's very happy to have our colleagues here to discuss some new information from this year ESMO meeting. So we have, at the beginning, I've introduced our panelists. First is the Dr. Tetsuya Mitsutomi from Kinki University, Osaka, Japan. From Pasiyani Dana-Farber Cancer Institute, Boston, USA, and Xiuning Le from MD Anderson, Houston, USA. And I'm Dr. Li Zhang from Sun Yat-sen University, Guangzhou, China. So at the beginning, I will present some interesting abstract in this year ESMO meeting, and then we will have a panel discussion. So first slides I will present is a BLB01D1 first-in-class, the EGFR HER3 bispecific antibody drug conjugate in patients with non-small cell lung cancer, updated result from first-in-human phase 1 study. So BLB01D1 is the first-in-class ADC consisting of EGFR and HER3 bispecific antibody bound to a novel topo-1 inhibitor payload via cleavable linkers. This year ASCO meetings, we already reported these drugs in non-small cell lung cancer and other solid tumors. So this year in ESMO meetings, we updated the lung cohort efficacy and also the safety from all the patients that are enrollment in every 3 weeks. So this is the overall response of the lung cancers. Totally, we have 102 patients that was enrolled in total. Response rate, confirmed response rate was 39%, and median DOR was 8.5, and median PFS was 5.6. Interestingly, we can see here the patients with non-CNS metastatic or treated CNS metastatic have a better confirmed response rate, median DOR, and also median PFS. So this is the overall safety of the data. Totally, we already have 369 patients enrolled. The TRAE was 95%, and grade 3 and above TRAE was 61%. The mainly toxicity was myelosuppression, which is the neutropenia, anemia, and thrombocytopenia. Only 1 patient that have grade 2 ILD was observed, so targeted toxicity was relatively lower. So the updated result demonstrated this drug will have promising anti-tumor activities in patients with non-small cell lung cancer who progressed after standard of care, and difference in ORR and PFS was observed in patients without CNS metastasis versus patients with CNS metastasis. The safety data is showing the profile was consistent with the previously reported, and there was no safety signal was seen among nearly 369 patients. So the next abstract we're going to present is a very famous one, is the Keynote 678 studies, which is a preoperative pembrolizumab for early-stage non-small cell lung cancer patient. This report is already, this year ASCO meetings, that they have reported the first interim analysis. This year's Dr. Jonasa report and the second interim analysis of overall survival data. So this is the study design. Patients with stage 2 or stage A and B, which is N1 positive patients, was enrolled. Patients who have treatment naive. Will also patient had to be undergoing resectable populations. And when then patient was randomized to receive the pembrolizumab plus cisplatin, cisgem or cis-pem, and versus the placebo plus the cisgem and also cis-pem. And patient was 4 cycles of treatment and then go to the surgery. After the surgery, in the treatment arm, the pembo was continuous for 13 cycles, or placebo continues with 13 cycles. The primary endpoint of the study was event-free survival per investigator, reviewer, and overall survival. So the key secondary primary endpoint was MPR and PCR, also the safety data. So this is already reported this year ASCO meetings for first interim analysis for events-free survival, EFS result. Here you can see the new adjuvant pembo plus chemo followed by surgery and adjuvant pembrolizumab significantly improved the EFS, MPR, and PCR. This is this year's already reported in ASCO meetings. So this year is the ESMO meetings. We have overall survival data, which is the second interim analysis. The median follow-up time is 3 years. So here you can see pembo arms, the median OS was not reached. But in the placebo arms, the median OS was 52 months. So the HR was 0.72 and p-value was 0.005. So also it's a significant result of the overall survival data. So the toxicity, here you can see the treatment-related AE clearly is a little bit higher in the grade 3 above in the pembo arms, but the treatment related to death is only 1%. Also, IRAE was also higher in pembo arms, but the IRAE led to death is only 1 patient, 0.3%. So this is the summary. Clearly, we can see the clinical improvement of overall survival improvement was seen in new adjuvant pembo plus the chemotherapy followed by surgery and adjuvant pembo versus the chemotherapy and the surgery alone. So we have 3 years follow-up. The hazard ratio was 0.72 and p-value was significant. The safety profile, also the EFS benefit was also seen in interim analysis 2, which is almost 2.5 years longer in the pembo arms. The toxicity profile was consistent with interim analysis 1 and no new safety signals. Based on this data, US FDA already approved this indication, which is the pembo, a new introduction for the resectable lung cancer patients. So the third abstract is also presented by me in this year is the mid-oral section. Is updated study result of the palbociclib combined with osimertinib in patients with EGFR mutant non-small cell lung cancer. So this is palbociclib. Palbociclib is the BCL2 and the BCLX inhibitors. In clinical models, they already have very promising anti-tumor activity data available. So in last year ESMO ASCO meetings, we already reported the preliminary data of this combination in EGFR mutant non-small cell lung cancer. So this year we just updated the safety and the clinical response data in non-small cell lung cancer patients. So this is the study design. The first part is the dose determination part. In this part, RP2D was established. Palbociclib was 160 milligrams IV every week, and osimertinib 80 milligrams every day. And then we come to the second part is the cohort expansion part. In this part, 2 arms was included. One arm is the third generation EGFR TKI resistant population, and arm 2 is the osimertinib naive population. So this is the overall study result. Overall, the objective response was 47%, and DOR was the 86%. You can see clearly the TKI naive population have a better tumor response. Toxicity was a study result was showing here. The TRAE was 92%. Grade 3 and above TRAE was 20%. The main toxicity was elevation of the liver enzyme and the thrombocytopenia. The toxicity profile is almost consistent with last year ASCO meeting reported. So in conclusion, paclitaxel combined with osimertinib exhibit a preliminary tolerable safety and comparable efficacy in patients with TKI naive or TKI pretreated population. This combination may improve the clinical outcome of patients with EGFR TKI harbors and also TP53 mutation population. Patients with BCLX expression experience a better efficacy with longer PFS. Of course, this study sample is limited. We need more patients. So further studies are worried. So this is the 3 abstracts I present. Next, I will ask the Xiuning Le will present the other 3 abstracts, please.
Yes, thank you, Dr. Zhang, for having me. Really, it's an honor to talk about what we learned at this year's ESMO. Very exciting data come out in the first-line landscape for how to treat EGFR mutant non-small cell lung cancer. So currently in the United States, our standard of care for metastatic classical EGFR mutant non-small cell lung cancer is offering patient osimertinib, which is a great medicine. It's a chemo pill once a day, very well tolerated, and the frontline progression-free survival is excellent. In FLAURA1 trial is 18.9 months, and with good CNS control. However, we still need to continue to improve upon what we have. We start to think, should we intensify our osimertinib treatment, adding additional agent to the frontline setting? Can we achieve additional benefit? Such examples include the FLAURA2 trial that we'll talk about in a few minutes. Ramosi trial is what I presented this year at ESMO, and the Mariposa trial also is a major presentation at ESMO. When we look at those 3 different trials, they take 3 completely different strategies. FLAURA2 is adding chemotherapy, carboplatin pemetrexed, to osimertinib. Ramosi trial add a anti-VEGF agent, ramucirumab, which is a VEGF receptor 2. And the Mariposa adds an antibody drug, which is EGFR and MET bispecific antibody to a highly effective EGFR TKI. So 3 completely different approaches here. The field, we know that osimertinib works really great. Then the intensification question comes to, can we identify high-risk patients and high-risk subgroups so that we can prolong the benefit in those patients who usually perform poorly? That also help us to justify the side effects and inconvenience. In fact, all 3 intensification strategies will involve IV treatment. Even just the logistical part has to be justified with clinical benefit. So let's look at the 3 studies first. I will be talking about FLAURA2, which is presented by Dr. Pasiani today, sitting in the panel about a month ago. So this is a large international randomized phase 3 study, enrolled over 500 patients and asking the question, if we add carboplatin pemetrexed to osimertinib compared to osimertinib itself, can we achieve additional benefit? The primary endpoint of this study is progression-free survival evaluated by investigator. And here, the trial is a positive study with statistically significant benefit of 25.5 months versus osimertinib monotherapy 16.7 months, a hazard ratio of 0.62. As you can see, the curve separate quite early and maintain the trend. One of the areas is worth paying attention is the subgroup analysis in patients who have brain metastases. Really, it's a nice benefit and a nice curve separation where the osimertinib with chemotherapy provides significant prolongation of PFS. The hazard ratio is under 0.5. That really means it's double the protection for CNS metastasis patients. Overall, the safety signal is consistent with we know about osimertinib as well as chemo, because we use chemo so routinely in clinic. This study didn't show additional safety signal, and everything is expected to be the additive effect. So in conclusion, FLAURA2 was a positive study showing that the addition of chemotherapy to osimertinib is superior in terms of prolonging progression-free survival in the first line. And then the subgroup analysis showed very strong evidence in a CNS metastasis patient population, and we look forward to see additional biomarker data from this trial. So the next study is what we present here at ESMO this year, RAMOSI trial. This is a randomized phase 2 study. It's a smaller study. Compare osimertinib with ramucirumab given at 10 milligrams per kilo every 3 weeks compared to osimertinib. Randomized 2-to-1 manner, we enrolled about 150 patients. This is a United States only study, which is quite different than the other global study we're talking about. So here's the primary endpoint. Very similar to FLAURA2, we used the progression-free survival by investigators as the initial primary endpoint. The study is positive, showing that the combination gives you the PFS of 24.8 compared to monotherapy 15.6, hazard ratio 0.55, statistically significant. The toxicity profile showed very expected, very similar to FLAURA2. Those two drugs, RAMOSI already used in clinic, so that we see hypertension, we see a little bit increase of nose bleeding, but there's no new safety signal, and then both patients and physicians are very comfortable using this combination. The third study is Mariposa, just reported a couple of hours ago about their primary endpoint. This Mariposa is a 3-arm international study. The trial enrolled over 1,000 patients globally. Basically, the biggest comparator, the initial comparison is amivantamab plus lazertinib compared to osimertinib. So this is their primary endpoint, is progression-free survival. I do want to bring to your attention that their progression survival was evaluated by a central committee. Their curve separates, and then they have statistical significance, hazard ratio 0.70. So the double render a 23.7 months versus monotherapy 16.6 months. When we look at the study, because amivantamab is relatively new to the oncology field, this study do show that grade 3 or higher adverse events was observed in 75% of the patients compared to osimertinib, that's much lower. And then there is a risk of leading to death. Overall, the presenters break down into EGFR class effect, MET class effect. Overall, we do understand because amivantamab's bispecific nature. However, this is a combination I think we, as a field, will have to learn how to manage the toxicity. Well, we don't supposed to compare trials, but I think since we're here learning all the exciting data in the quick 1 month, multiple positive studies came out. So I did do a quick summary here. FLAURA2 and Mariposa, large international study, over 1,000 patients. RAMOSI is a much, much smaller study, so we have to interpret that carefully. In terms of efficacy, all three showed positive results, ballpark in the 0.5 to 0.6 to 0.7 ballpark to improve the PFS. So I do want to point out the FLAURA2, although the primary endpoint is the investigator-evaluated PFS. However, the trial did report out independent committee reported PFS, which is almost 30 months. So it's the best performance of all three studies. And in the subgroup analysis, CNS metastasis patient actually across the board had benefit. Last but not least, really not least, I put the grade 3 toxicity comparator there. As you can see, some of the trials having much higher number, so we have to use those regimens probably with a lot of caution.
So thank you for Dr. Xiuning Le presented this three very interesting abstract. So next we will have some panel discussion. I think it's that we because the time of the limited, we have focusing on the the three topic. One is two topics. One is EGFR mutant non-small cell lung cancer, and the other one is perioperative chemotherapy and immunotherapy. So this is a very interesting two topics. So passing all.
So yeah, I know a lot of information at ESMO this year. So Dr. Lee, how do you take all the learnings from all the advances or recent advances in the EGFR setting, in the newly diagnosed metastatic EGFR setting? What do you tell your patient next week?
Yeah.
What do you tell him or her, or how do you choose between the various options? Are there?
Yeah. I think it's, your question is very, very interesting questions. So we have a lot of third generation chemotherapy, third generation EGFR TKI available right now in China, even for the osimertinib only in other countries. But here in China, so we have firstly, the question is which one we used. And the second one is are we used only EGFR TKI, or should we use the combination? So it's especially for the FLAURA2 updated data for this year ESMO meetings. Can we use only for brain metastatic population, or can we use the other? So I think this is a very interesting question. So I was thinking about how your opinions.
Yeah, I think clearly the FLAURA2 trial and the Mariposa trial show that you can have a more intensified regimen, a combination regimen, and that can produce an improvement in progression-free survival compared to osimertinib in an all-comer population. I don't think that, however, tells you who needs those combinations, who is likely to benefit from those combinations. And I think there are certainly individuals who do very well with single-agent osimertinib or single-agent third-generation EGFR TKI. And I think what we need to try to work on as a community is to try to understand, are there clinical, molecular features, other components of the patient's presentation or their tumor that would make you choose an intensified regimen over single-agent osimertinib?
I don't have to wait until next week. Thursday, I have to go to clinic, so I face that question immediately. I felt like we do have very, very strong data in CNS with FLAURA2. I think the hazard ratio 0.47. Also, Dr. Blanchard also presented the CNS subgroup analysis, very consistent in all parameters showing benefit. So if the patient comes with CNS metastasis, I probably will start to offer that. Currently, amivantamab is not immediately available in this setting, so I don't have to face that problem for a little bit. I do think all three trials, especially the two large ones, hasn't reported out the biomarker commutation part of the results. That will also guide us how to pick and choose.
So how about you about the Dr. Isoto?
Yeah, thank you very much. So this year we had a lot of the papers, and now we have a lot of the options. So many options. So that makes us the selection very difficult. But however, we have to think about the balance between the toxicity and the efficacy, of course. And these days the patient journey is getting longer, so even after the PFS, the patient lives longer than that. So we have to also think about the later treatment. So in general, so as you said, the brain mets patients may be better treated by the FLAURA2 regimen, but in general, I think you stick to the osimertinib monotherapy, and you showed the OC plus ramucirumab was better than osimertinib, but our Japanese study did not show any difference. And also in the case of the erlotinib, it prolongs the PFS but not OS. So I'm a bit skeptical to use angiotensin inhibitors. And the Mariposa actually prolongs the PFS, but it looks to me it's a bit toxic, and also it is not available in Japan. So still, if I see the patient with the first-line EGFR patients, I may offer the osimertinib.
Okay. So how about your opinion, Pessy, the anti-VEGF plus osimertinib?
Yeah, we've clearly had sort of mixed results of studies, not just the ones that were presented here today, but prior studies that have added anti-angiogenic agents either in the front line or in the second line with osimertinib have all been negative, even for PFS. So clearly there's some some heterogeneity in the data sets. And there is a ECOG randomized trial, I believe, still ongoing with Bev? Right, so it's osimertinib, bevacizumab versus osimertinib. I don't know where that is in terms of its...
I think it enrolled probably 1/3, so still have time.
Still have time, can enroll patients into that. So for me, I would probably also think about single agent osimertinib or maybe chemotherapy, somebody with brain metastases, other features. You know, if I was worried about them and they needed to have a response to the treatment, probably chemotherapy would make sense at that point as well. But I do think we need to kind of understand or figure out what features would dictate that. And I think also another piece that's important, kind of related to what Dr. Mitsudomi said, is that we also do need to think a little bit about the subsequent therapies. And so I think an important question for the FLAURA2 regimen or the amivantamab lazertinib regimen is does the resistance spectrum continue to look the same as it does a single agent osimertinib? Because if it's shifted somehow, that may limit our subsequent options or make us think about what's the right approach. So I think there's still some more work to be done.
So question for the Dr. Lers. Are you trying to initiate the phase 4, based on your data, are you trying to initiate the phase 3 studies in RAM plus osimertinib, or you stop there?
Currently, that's not the plan. We're waiting for the ECOG study to either support or deprioritize. I do feel now we have multiple different options. Is it possible to do a relative, like head-to-head study of different regimen? Probably gonna not be supported by certain pharma companies, but I think if there's some co-op group might help. Also, even the endpoint being patients' quality of life, I think that will also be very meaningful. Because if we see the efficacy in the same ballpark, then the quality of life plays a big role.
Median overall survival with patients who are newly diagnosed with advanced EGFR mutant lung cancer is multiple years, 3 to 4 years. And so absolutely echo that sentiment that has to be a consideration there. And, you know, looking at not just the typical tables where we look at the different events, but also patient-reported outcomes and other measures like that, I think will be important to integrate into that decision-making.
So this year, we already reported the ADC combined with the ADC treatment for EGFR mutants populations. Do you guys think the ADC will be another choice of treatment for EGFR mutant population?
I think there are, yes, absolutely. And that treatment approach can be after frontline osimertinib or even combined with osimertinib. And so there's obviously the HER3 ADC, the one that you talked about, the bispecific ADC, and then Dato-DXd,
TROP2 ADC.
Dato-DXd. So I think there are I absolutely think so. That's an option, and that could be an option. Maybe if you start somebody in the front line with a single agent osimertinib, ADC could be a second line option, or where you would normally think about a cytotoxic therapy, be it chemotherapy alone or Mariposa 2 regimen or whatnot. There, I think the ADC makes sense, and I think this. And we also saw at ESMO this year that ADCs can also have both HER3 and HER2 ADCs can also have intracranial activity, which I don't know that we sort of thought that was a given. They tend to be big molecules, but there was data from both agents, so I think that hopefully will continue to be the case.
But I don't like with ADCs, we cannot select the patients by biomarkers. So I don't understand why it works.
Yeah, I think there continues to be a need also for biomarker development to get to Tetsuya's point about being able to select patients preferentially.
Okay. So let's transfer to the immunotherapy for the perioperative patients. Based on the data that we have in the Keynote 671, are we selected the patient, or we used all the comers to neoadjuvant immunotherapy? Is there any new ideas about the FDA already approved this indication, right?
Approved, right.
Are we use the all comers, or can we use the select of patients by PD-L1 expression or something like that?
Well, I think the studies have clearly shown that higher level of PD-L1 does seem to correlate with greater efficacy. So I think, I think that will be an important part of the discussion of choosing therapies, and also whether you would use those regimens in patients with EGFR mutations or ALK rearrangements, maybe not.
Okay. So how about your opinion?
So the question is whether we should use the perioperative neoadjuvant or postoperative, right? And there are several perioperative regimens, also adjuvant regimens. So the question is, one first question should be, which of the three strategies should we choose, right? So that is related to the patient, the tumor status, like NO2 disease, or how big, so it's a pneumonectomy is required, or how the pulmonary function, what's the organ function, those kind of things. I mean, how many lymph nodes. So it's not that simple. I mean, PD-L1, even the PD-L1 is negative, then sometimes we may choose the neoadjuvant approach, or even the PD-L1 is very high, but the patient appears not to tolerate the surgery, then so we have to think of many things. So that's why that many people recommend the MDT, right? So
it's a good to have multidisciplinary tumor discussions and to get the best
Treatment of choice.
Yes.
Okay.
Yes.
Yeah, but it's very difficult. We don't have the one strict rule. No.
Yeah, because we have three options. One is the neoadjuvant, the other is adjuvant, and then perioperative.
And also, even in the neoadjuvant, there are how many courses before the 3 courses or 4 courses, or whether we should need a postoperative adjuvant part. That's a big question too.
And I think obviously stage is important there too. You may not want to do neoadjuvant therapy for stage 1 lung cancer, whereas if you have lymph node positive disease, stage 2, stage 3, those may be individuals who are at higher risk and that may be more likely to benefit from the neoadjuvant or perioperative approach.
So, Professor,
how
about your
So other than the 671, my colleague Dr. Tina Casconi also presented the 77T, where use nivolumab both pre and post-operate. And then I felt the two trials, the data were pretty consistent in terms of rendering benefits. Both show that higher stage will benefit more, higher PD-L1 will benefit more. And then earlier this year, we also have a Aegean study. So I start to feel I'm probably going to move towards the perioperative immune.
Do you perceive any difference between the neoadjuvant one and perioperative? It's also similar, right?
I know. Clinically, I feel very comfortable offering immunotherapy as maintenance because we have already learned from Pacific how to manage those patients, and we'll stop if there's certain toxicities. In terms of clinical practice, I feel pretty comfortable in the adjuvant setting.
But no one proves the.
Although for the patient, the neoadjuvant approach only is easier, right? Because it's limited number of chemotherapy, IO. If you have a good response, successful surgery, you're done. And so there's an appeal to that, and of course, we haven't tested the need for the adjuvant portion following neoadjuvant chemo IO in a randomized trial. But so I think it'll continue to evolve.
But the pharma will not be interested in to run such kind of a trial, right? With plus minus adjuvant. That kind of trial should be
it's a tough. Yeah, it's a tough trial. That may be a cooperative group trial. But it's a tough trial. And maybe there, I think, if you see somebody had a path CR, you could say, okay, well, person's clearly responding to immune checkpoint inhibition, and that may go into the decision making of giving adjuvant, or sort of the we're done kind of a statement that and
maybe even adding in ctDNA.
Yeah, you can add other so other
one for me too, right?
Currently available ctDNA testing by such kind of a ctDNA testing, most of the patients are cleared after surgery. So you cannot use that.
The population is too
small. The
small.
sensitivity is not good enough. So if it's still positive, that patient may be very bad. But
is there any randomized trials to compare neoadjuvant, adjuvant, or perioperative? Is there any ongoing studies?
I don't think any of the
I
ongoing
think that some
studies.
group is planning.
Is planning.
Yeah, that's what I
It will
heard.
be a very big study, long-term study,
that-
because
And it will take a long time, right?
yes, it take a long term. So we are talking. We still have some little bit of time. So, can we? I think it's as a part of this non-small cell lung cancer improvement. Are there any new significant improvement in lung cancer or in small cell lung cancer?
Well, small cell lung cancer, there was a presentation on the tarlatamab, the DLL3 bispecific T-cell engager.
Okay.
And that strategy and that study showed a very good degree of activity. And in previously treated small cell, and traditionally patients with previously treated small cell, new therapies don't always work very well or work for a limited period of time. Patients can respond, but the durability is often quite short. And I think here it was very encouraging, I thought. And,
I think the data is around a year for small cell refractory to prior chemo. That was quite impressive.
Yeah.
I think that the Papillon trial was interesting, and exon 20 insertions are relatively common.
Oh yeah.
Not so very rare. So
okay.
We often see the patients with exon 20 insertion, but so far we cannot do anything other than just giving the chemotherapy. But if the amivantam is approved in the future in Japan, it's not approved yet, even for the exon 20. But that combination amivantam with chemo will be the very certainly practice changing.
And currently in the U.S., it's approved in the second-line setting as a single agent following platinum-based chemotherapy. But I think the Papillon trial really may change that. There was a doubling of the PFS with chemotherapy, amivantamab compared to chemotherapy. So I think that's a pretty big difference, and I suspect that could lead to a full regulatory approval, and then it would become a potential option in the frontline space. And there still are many kinase inhibitors.
You think the potential option was standard of care?
What's that? I think it could become standard of care.
Yeah.
I mean, it was a very big improvement.
Yeah.
Yeah,
I agree. I think both the PFS almost doubled from 6 months to 11, and then the response rate is also much, much higher. So we were talking earlier, I think if on Thursday I have a patient, I might offer that if insurance gives it to me. Yeah.
Can you use it?
If insurance approves. Yeah.
Okay.
it would be off-label
Insurance
use
company.
at the moment,
Okay.
but I suspect I hope that would get regulatory approval. It'd be nice to have that option available. And there are, of course, still a number of EGFR exon 20 specific kinase inhibitors out in clinical development.
One of the reports that Pasi alluded to earlier is the HER3 ADC. They reported excellent brain protection in their patient population. The analysis was also quite elegant, separating into different patient groups, including no brain mets look at outcome, half brain mets radiated versus not. So it really opened the door of thinking about ADC could actually help CNS metastasis. It was a quite nice presentation.
Yeah, agreed. So in patients with untreated brain metastases, there was about a 33% response rate, which seemed pretty high. And there was activity in patients who had previously been treated, typically with radiation, but it's a little bit harder to interpret that with the prior radiation.
Actually, I think in breast cancer, they already have some experience now for.
with HER2.
Yeah, with HER2. So,
Yeah.
So okay, so time is limited, but I think it's very, very interesting to talk about the lung cancer treatment, especially for EGFR mutant population and palliative immunotherapy in lung cancer in this year ESMO meetings. I think some of the evidence could change our practice. For example, for the palliative immunotherapy, we know the US FDA already approved the indications, but also we also need further evidence for other options, like a combination of EGFR TKI with other combinations, like ADC or like BCL2 or BCLX combinations. So I think this is a very, very interesting. I thank you all the panelists to join our discussions, and thank you for your attention. Thank you.
Thank you.
Thank you.
Thank you.